Next we have pharmacodynamics. Actually, I tell you what, I want to insert something here, then we'll get right to this. This is something that bugs me, because I go around giving talks, and I hear this relatively frequently. Dr. So-and-so in our town, in Seattle or wherever, takes blood tests and measures norepinephrine and serotonin levels in the blood and then can determine which drug to start with. And I wish that were the case. That is complete hogwash. And I'll tell you why. Okay? First off, 90% of serotonin that is made is outside the brain. And most of it's in the gut, in the intestines. So you go to measure blood levels of serotonin, it tells you nothing about blood levels in the brain. Okay? Also, norepinephrine. Every nerve in the sympathetic nervous system, like we've talked about, is constantly shooting norepinephrine out in the system. You got 40,000 nerves up here, and you probably have hundreds of millions of nerves out here that squirt out norepinephrine. Again, take a blood sample. Where's it coming from? The body or the brain? So, it's just bogus. I mean, it would be great if you could do that. You can measure BDNF levels, you can measure cortisol levels, okay, but you can't measure these neurotransmitter levels, except in spinal fluid, okay? But that is never done because it's too dangerous. Okay, so anyway, getting back to this, again, we're talking pharmacodynamics, just a couple of things about drug interactions at the level of the nerve cell, all right? A number of drugs are reuptake inhibitors, okay? So and probably, all of us know this, but when the neurotransmitter is dumped into the synapse, it is rapidly reabsorbed into the nerve cell, packaged in vesicles and used again and again. And this is reuptake. And there are people that are genetically born with fewer reuptake transporters, and others that have more than normal. So once again, we have some individual variability. It doesn't have to do with life experiences as much as with genetics. But the point here is that reuptake is a natural process occurring really in all nerve cells, and it's a way of conserving energy because it takes energy to make neurotransmitters. It takes raw materials, amino acids. This is recycling on a biological level. Now, one way to increase the availability of neurotransmitter in the synapse is to block reuptake. And this is what you see with most of the antidepressants. Okay, they are reuptake inhibitors. Also with stimulants. Stimulants are dopamine reuptake inhibitors. Okay, they work in the dopamine system. So what happens then is that if you just start on an SSRI, let's say Zoloft, typically within a couple of hours, that drug is through the gut, through the liver, in the bloodstream, and up here actively blocking reuptake. Now, what happens here is that the way these drugs work, chemically, the actual shape of the molecule is similar enough to, in this case, we'll say this is a serotonin nerve cell. It's close enough to serotonin that it can actually occupy and block access to the reuptake pore that normally is going to suck up only serotonin. Okay, it's kind of like a Trojan horse. It's close enough to it, doesn't get sucked into the cell, but it blocks the opening. But just transiently, then it gets bumped off. But then here along comes another Zoloft molecule, and that occupies that as well. So that's reuptake blockade. All right. So you get somebody who's got major depression and you give them an SSRI and you push the dose and you get aggressive, probably around 50% of people are going to have a response because not all depressions are due to serotonin. All right? And one of the major places it'll have a response is in the hypothalamus. So you start to see sleep getting regulated better. Appetite, sex drive returning to normal. And there are other parts of the brain as well. Here the drugs have an antidepressant effect, and all of the drugs in this class were originally FDA approved to treat depression, so they carry the name antidepressant. Okay? However, it was discovered that many of these drugs, and this is true for really all of the antidepressants except Wellbutrin, are very good anti-anxiety drugs. In fact, they are better at treating anxiety than they are treating depression. Greater efficacy. But it was found by accident that they also treat anxiety disorders, like panic attack, for instance, or generalized anxiety. And some companies will go back and spend the money to get FDA approval for, let's say, like Paxil has FDA approval for treating social anxiety disorder, for instance. But a lot of the SSRIs don't, but they're used frequently for treating social anxiety disorder. You don't have to have FDA approval as long as there's clinical research or standard practice that these drugs work, then you can use the drugs for other things. It's called off-label prescribing. All right? Now, what happens then is a person has panic disorder, it has maybe no depression. The part of the brain that's going to be affected is very different than what happens in treating major depression. And a lot of it is occurring down here in the locus coeruleus, in the brainstem. So it's an antidepressant, but actually it's an anti-panic drug. And some patients will get on the internet, and you know, this is another variable we got to really contend with, is everybody here knows, right, that the internet, you get on there and it's always accurate information, right? I'm just being facetious. Sometimes it's good information. Sometimes people get on the internet and put up stuff there that's a bunch of baloney, or you know, it's exaggerated or inaccurate or what have you. But some people will get on the internet and they'll go back to their doctor or their therapist. I'm not depressed. You know, they give me an antidepressant, but I have panic attacks. So I have to explain to them about this. Now, also, remember I said before that it's down here in the gut. Where you have probably 90% of the serotonin is made and used in the body, and it turns out that GI side effects are very common with drugs that increase serotonin. They can produce gas, diarrhea, and nausea, and sometimes vomiting. But usually nausea is the biggest one, but you can get intestinal gas and diarrhea. Now, the drug companies were very wise when they decided, let's call these antidepressants instead of gas, nausea, diarrhea drugs, because we'll probably sell a lot more if we do that. Okay, and Effexor actually, which is a very, very good antidepressant for severe depressions. When it first came out, it got the name Cytofexor because it had lots of GI side effects. And I've had patients who really have trouble you know, with the nausea that you get with Effexor. All right. Here, take this, but make sure you get home in 90 seconds. Okay. Now, a part of what we have to do is educate our clients about the time for onset of action. Oftentimes, the side effects are felt sometimes within hours, but the drugs may take longer than that. And basically, excuse me, two classes of drugs really can start to show some effect within 30-45 minutes, at least by an hour. And these are the benzodiazepines, the tranquilizers, and stimulants. However, really all the other drugs require oftentimes weeks. There's one notable exception to this, and we'll get into detail about this either this afternoon or next class, and that is the treatment of premenstrual dysphoric disorder. You can take an antidepressant, and within 3 or 4 hours, the symptoms start to go away. Okay, that's the one exception. Okay, now let's just go back here. Remember this morning I showed you a cartoon. It showed a nerve cell, and we talked about second messengers. Okay, now part of what is getting derailed. Now this is all theory, although it's supported by some data, obviously. Is there's a decreased availability of a neurotransmitter, but over probably a period of weeks or months. And what's happening in this nerve cell down here is its internal chemistry is getting very off track. Okay, so what happens then, if you can restore the normal amount of the neurotransmitter here, then it will begin to gradually affect those metabotropic receptors to move the chemistry of the adjacent cell back to a normal state. Now, I'll go into much more detail about premenstrual dysphoria later, but PMDD is very different in several ways. In one way, very acute onset, okay, within hours. Women who have this will start feeling very depressed or irritable or anxious, all right? And it lasts for a discrete period of time. Now, some women, fortunately, it's just 1 day a month. Some women, it's 9 days a month. It typically is the same number of days for each individual woman, okay? But it also has an abrupt offset. So here we have a different kind of disorder that you can have symptoms that are as severe and as debilitating as major depression that come on within hours and may last 3 days and go away. That's not enough time for these significant changes in second messengers to occur. Okay, there's a different mechanism of action. So you might get a test question that says, how long does it take for antidepressant to start engaging in reuptake inhibition? And the right answer would be a couple hours. How long does it typically take for an antidepressant to start showing symptomatic improvement? At least 2 weeks, if not longer. Okay?